I think it's very important for all of you to stay and listen about adult immunizations. Really, we don't appreciate the contribution they make to health and longevity, and that's especially true in our minority community. So we are going to share with you some information about why it's so important and how to effectively increase adult immunizations. And this will go into another session following this in the other ballroom, a CME session where you will actually hear the recommendations. You'll learn how one doctor made a mint immunizing, made a good living immunizing, and what policy barriers we need to attack. I am Laura Lee Hall, the moderator of this session, and I am the COO and SVP of Gary Puckrin's new organization, Sustainable Healthy Communities. I hope everyone here will email me. I have my email address up on the last slide, and figure out a way we can work together in your community. We have a very prestigious guest panel here who've been working with me in this role and my previous role at the American College of Physicians on this topic. First, you'll hear from Dr. Rosof, who actually serves as the CEO of Sustainable Healthy Communities, but has been involved internationally as a health quality leader. Dr. Ferguson hails from, I guess it's southern Georgia, where she works with colleagues in 5 or 6 practices that are part of a community health center. And it's amazing the quality improvement work that they do there, and we're delighted that she'll share her experience. And then finally, the young'un on the block is Patrick Maloney, who is our evaluation partner at LSU, works with Dr. Kalk, who is seated over, waving his hand. And so they actually help us understand how to evaluate our programs. That's the panel. I already told you that we are Sustainable Healthy Communities, wholly owned subsidiary of NMQF, and we will be in the business of using the vast data resources and community connections that Gary has established over the last 15 years and translating that into actionable programs around the country. So our vision is sustainable, healthy communities in every zip code, paradigm changing, I think we're calling it. Our mission is to promote such communities, especially those with diverse and underserved populations, through actionable data, research, and engagement of clinicians and community leaders. Why, say you? I don't know. There we go. I'm not going to really speak to data. You can just look at the color lines and see that we really are failing as a country in terms of immunizing. This is flu, and people of color are really disadvantaged. And it hasn't really improved, which is kind of remarkable to me. And this is the most recent data from the CDC showing that it continues along this very poor path. What we do in this project and in others is basically build a clinician network, leaders who are able to implement in their own practice, using their team, their strengths, their interest, and our tools to change the workflow so their patients can benefit. I mean, that is really quite simply how we do the clinician training. You get personalized practice coaches who, by the way, are your peers, so they know what you've been through and can help you move forward. Sorry, I'm taking up time with the clicker. I just show you this without going through the numbers to help you become a believer that the approach of peer-to-peer coaching and support really leads to significant change in practice. So the big blue bars are actually changes that were made when a practice chose a topic that they really wanted to work on. So we'll help you change, and if it's something you have a passion for, your numbers will really go up. This has spilled over into the community without us even trying, in that physicians, members of the practice, other folks in the community have wanted to get the word out, speaking to employers in the community about the importance of immunization, writing op-ed pieces, being on the radio. So we are adding, as we've joined with NMQF, an element of community champion training as well, so that the whole environment in which the practice is located is supportive of the health promoting activities. And by the way, we didn't have to invent the methodology. This is a chart from a CDC report on promoting health equity in sustainable, healthy communities. So it takes leaders like you, in essence, to develop an action plan. Last year, the National Minority Quality Forum, ACP, and Bernie's group got together to really focus on minorities and adult immunization. Each of us had a role, NMQF with the data, QHC with the environmental scan, LSU with really looking at the characteristics of the providers, and ACP in translating that into QI and training activities. I'm gonna move ahead. The only thing I will note is that a funny thing happened on the way through looking at the Medicare data. There are a few physicians, few probably is the operative word I fear, who are super immunizers. They are doing it. They're doing it systematically in their practice, and a lot of our research is really gonna focus on these folks who have made it happen so we can understand how and why and what, but maybe more importantly, recruit them to work with peers to help them help their patients in this fashion. We have an amazing advisory group. Some of you are in the audience, and I thank all of you. And I'm glad to share these slides, by the way, if you're interested in them. We have already completed one part of the project, that is reviewing the evidence base, what really works in helping to raise adult immunization rates among people of color. And you know, it is being published in the journal Vaccine. It's funny, we thought about, should we go to a journal that focuses on health equity, or should we go to the preeminent journal that vaccinators read and scientists in that world read? And so we chose the latter, feeling that we'd have a bigger impact of making this an issue. And we got accepted. And our review basically says there's lots to be learned, but that probably the most fruitful way forward at this point in time is really to work with physician practices, because that's who patients trust. So as I said, if you want to join the effort, please email me. And now let's listen to our guest here as they talk about some of the elements of the program. Bernie, you're up first.
No slides. Are we on with the slides?
Switching to you, it looks like.
In any event, I must say, first of all, I couldn't be more pleased to be here. And I must say how impressed I was with the morning session. It resonated well with what we're doing. It resonated well with what our future is in healthcare. And it really was an important beginning to the next 2 days. A quick story. Gary and I have been working together for about 2 years. And we have been on a number of panels together. We speak together rather regularly. And last year at the ACP meeting, American College of Physicians meeting, Gary and I were on a panel together. And the president got up and introduced both of us and said, these two guys, they have the same philosophy, the same goals. They're twins. Well, nobody could look any different than Gary and I. So when I got up to speak, I wanted to be sure to say, wanted the audience to really know that Gary and I are fraternal twins. So I'm going to talk a little bit about the social determinants of health and tie it into the immunization program that we have been discussing over the last number of years so successfully under the leadership of Laura Lee. And we heard a lot about that already this morning, but we do know that taking care of ourselves by eating well, exercising regularly, not smoking, getting the recommendation immunizations, which is what we're here to speak about, and screening tests, and choosing wisely, which is being discussed next door, and seeing a doctor when ill, all influence our health. No question about that. Health is also determined in part by access to social and economic opportunities, the resources and supports available in our homes, neighborhoods, and communities. And I must say, the word communities, I've been doing quality for a long while. The word communities first appeared in the quality literature only in the past decade. I think it began with the IOM crossing the quality chasm and to err is human. It's the first time we began to understand the importance of community in creating quality health. The safety of our workplace and our neighborhoods, the cleanliness of our water, food and air, and this whole issue about food deserts, which occur in multiple communities, and the nature of our social interactions and relationships. The conditions in which we live explain in part why some Americans are healthier than others, and why Americans more generally are not as healthy as they could be. The Commonwealth Report, Why Not the Very Best, really made that point by looking at how we as a nation compare to other industrialized nations and realize that we don't do as well as we could. So Healthy People 2020 emphasizes the importance of addressing the social determinants of health by including create social and physical environments that promote good health for all as one of the 4 overarching goals of the decade, and thus the discussion today. So I always like this statement because it leads the way. If I cannot do great things, I can do small things in a great way. And I think that's what we would like to do, to get to the next step. So Healthy People 2020, one of the 4 overarching goals for the decade, create social and physical environments that promote good health for all. Now, we've heard a lot about the zip code. We heard a lot about genetic code. To me, and I've been saying this to my medical students for a number of years now, the zip code is really more important than the genetic code. Because in many zip codes, you never live to your genetic code. Traditional clinical services account for only 10 to 20% of a population's health. Genetics account for 20%. That leaves us 50 to 70%, the social determinants of health, which will really make us healthier, longer lives, etc. So what are the 5 determinants of health of a population as defined by the CDC, biology and genetics, individual behavior, including alcohol use, drug use, and smoking, social environment, discrimination, income and gender, physical environment, again, the zip code, and health services, access to quality care. It's not access to care, it's access to quality care, and of course, it's health insurance. Education, employment, health systems and services, transportation and housing are defined by the National Academy, in addition to income and wealth, physical environment, public safety, and the social environment. Now, Healthy People 2020 define 5 areas in the social determinants of health. And it's important for us to take a look at that. 5 key areas include economic stability, education. By the way, childhood education, early childhood education, makes a difference in how you approach life. It's incredibly important. Social and community context, health and healthcare, neighborhood and built environment. The goal is to create social and physical environments that promote good health, including immunization, preventive care, and we'd like to focus on chronic disease, diabetes, cancer, etc. Economic stability includes poverty, employment, food security, and housing stability. Education, high school graduation, enrollment in higher education, language and literacy, and you hear a lot from me in the future about health literacy, and early childhood education and development. I can't emphasize that too much. Social and community context, social cohesion, civic participation, discrimination and incarceration, and health and healthcare, of course, access to primary care and health literacy. In the absence of a health literate population, in the absence of the ability to communicate adequately your important information about health and healthcare, you really can't get to the next step, and that is improving health for the community. And the neighborhood and built environment, access, quality of housing, crime and violence, and environmental conditions. Now, I referenced the Institute of Medicine and the initial reports back in 2001. It's about 15 years since this all began. And they really isolated priority areas for national action. They talked about getting better. They talked about acute care, preventive care, palliative care, and quality clinical care. The overarching area, cross-cutting, was self-management, health literacy, care coordination, impossible to achieve good health without care coordination, and this is all uniquely applicable to what we're talking about in preventive care and immunization, and any other chronic illness. The key dimensions were clearly defined by the IOM. Those were to be safe, effective, patient-centered. One should not be doing anything that we're doing around this room without centering that on the patient and the family, timely, equitable, and efficient. And promoting the health of populations, preventing and treatment of chronic disease really requires a systems approach. And that's really what began the IOM for understanding and addressing the social and environmental factors that can protect or undermine health. It's really a systems approach. The pathways to health equity and better outcomes is truly the community. I can't emphasize the importance of the community in our discussion to assure trust. There's considerable mistrust when it comes to medical care in many communities. Assemble the resources, provide the education, assure community services, assist in eliminating unscientific beliefs, by the way, which is one of the reasons for poor immunizations in many communities, and create and assemble the advocacy. The policy issues that have helped this, in addition, Affordable Care Act, many people may not realize, has many ingredients, which includes the requirement that nonprofit healthcare organizations demonstrate their community benefit beyond the usual charity care to include community health assessments, planning, implementation, and evaluation. The expectation is that healthcare organizations will provide a range of services that focus on improving health status and quality of life in local communities. Also, to explore how the programs, practices, and policies in the areas of social determinants affect the health of individuals, families, and communities, and establish common goals, complementary roles, and ongoing constructive relationships between the health sector and these areas, and maximize the opportunities for collaboration and account for social risk factors in performance measurement and payment. Now, we recently wrote a paper on professionalism for healthcare organizations, just published, as a matter of fact, this past month in Academic Medicine. And we recognize that the aspirational behaviors for healthcare organizations, we're talking about organizations as opposed to the original paper that was written for physicians, require 4 domains: patient partnership, organizational culture, community partnership, and operations and business practices. Once again, the community is focused in this professionalism paper to create healthy communities, address the social determinants of health, create strategic partnership with communities that healthcare organizations serve, define the barriers to health and healthcare, and use data to design interventions to maximize treatment of chronic illness. Access to data needs to be available. The National Minority Quality Forum and Sustainable Healthy Communities has a diabetes index data and other data which has informed the immunization project. There are clinical registries put out by the specialty societies, Genesis by the American College of Physicians, NSQIP by the American College of Surgeons. The thoracic surgeons have had a a registry for a long period of time, and Pinnacle by the Heart People. Performance measurement by HEDIS and QF. MACRA is a focus, although it's focused on reimbursement, it's a focus on improving health and, of course, population health. And altering the social determinants of health. What are the conclusions for what I was trying to say? The ecology of these determinants is really complex. You have to use data at the zip code level to determine community need, resource priorities, and research necessities. The CDC's Promoting Health Equity, a resource to help communities address social determinants of health, is a good resource for us to use. And we need to seek strategic partnerships between healthcare organizations. They have a responsibility, including pharma, payers, providers, patient advocates, local communities, and government, in order to improve the health of the community. And once again, I can emphasize the importance of the word community. So I'm going to stop here. We'll have questions later, and we'll focus on some of the issues that the panel will be discussing. Thank you.
Thanks, Bernie. Dr. Ferguson is next. We can bring her slides up. You see me fiddling with my phone. It's not something I'm trying to be rude about. I'm tweeting out. I encourage you to tweet as well and use the hashtag NMQF Summit, okay?
So again, I'm Dr. Frances Ferguson with Albany Area Primary Health Care in Southwest Georgia. And we participated in a project with the ACP called the ACP Quality Connect. And our goal was to raise the rates of immunizations in our organization. I had several partners who worked with me. We were considered the leadership champions in this project. Dr. Stelina Gowdy and Rhonda Haynes, one of our nurse practitioners. I assume I'm pushing the right button. Okay.
Just by the tape.
Yeah, I'm trying to go backwards.
On the right, okay.
Okay. I'll get it together here in a second. Okay, so part of the project, the goals that we had in terms of trying to increase immunization rates were, one, to implement some standards of care and some standards by which we would follow in order to increase our immunizations. We wanted to promote equity and as well as to use state registries. Georgia has a state registry for immunizations. And ultimately, the goal was to make immunizations a standard practice in general internal medicine. So our champions, what do the champions do? One was to lead our practice in setting the QI project. And the goal, of course, was to increase immunizations. We were to engage our peers in the process because many of the partners were a bit reluctant, or they felt like they were too busy to really promote immunizations. We were to teach our colleagues some strategies in order to promote immunizations, and just to promote immunizations in the community as a whole. So the project focused on several different vaccines, including influenza, pneumonia in older adults, as well as pneumonia in high-risk patients. The other immunizations kind of came along for the ride, so to speak, and that was the zoster vaccinations and tetanus and the Tdap as well. So this was just a bit of the action plan that we chose in order to increase our immunization rates. Initially, the goal was to look at the state registry, see whether or not the patient had been immunized, and then if they have been immunized, record it in our EMR. If they had not been immunized, then we would focus on those patients. We gave a handout to patients while they sat in the lobby. It was a handout that taught them about the vaccine, and it was at a level that they could understand, so they could read about the vaccine and perhaps dispel some of the myths that they had before they came to the back to see the nurses or to see their physicians. We had to train nurses on standing orders was the second element. We used some already standard guidelines for nurses, which included risk and benefits of the immunizations, how to give the immunizations, exactly what needle size to use, what patients to immunize, but the nurses were all given standing orders. Our DON went around to all of our different sites and taught the nurses how and who to give the vaccines to. We had a little bit more difficult time selling it to the providers. We had to educate them on using standing orders and allowing their nurses to use these standing orders. Sometimes we also had to give them talking points, because if the initial handout and the nurse could not convince the patient to get the vaccine, by the time they sat in front of the doctor, we were kind of the last frontier. So we had to know what to say in order to finally convince the person to get the vaccine. And then, of course, the administration of the vaccine was important, so the nurses had to know exactly what to do in order to administer the vaccine prior to seeing the physician. So that, usually there's that 15-minute wait time that patients have to wait after a vaccine. So if they have gotten the vaccine before they're even in the exam room, they don't have to wait any longer because they've had it and their wait time is over. We had a community component to our project, and so that involved outreach, making sure that the health departments were giving vaccines, that the hospitals were giving the vaccines. I work in nursing homes as well. It was making sure that the nursing homes also were giving the vaccines. And not only that, but using the state registry. So one of the big challenges is the hospital, because the hospital uniformly gives pneumonia and influenza vaccines to patients who are admitted, but they're not really documenting it so that anyone can find it. Except for children, the hospitals do not put immunizations in the state registry. And so it is difficult for the PCP, once the patient is discharged, to even know whether the person has been vaccinated or not. And believe it or not, patients don't know. Sometimes if their family members are with them at the time of discharge, they may know. Your patients just know, well, I got a bunch of shots in the hospital. I'm not sure whether I got a vaccine or not. They could have gotten sub-Q heparin on the day of discharge, and they tell you they got a shot, but that wasn't the appropriate shot. And so unless you had access to hospital records and could dig down into the bowels of the electronic record, it was difficult to figure out if the hospital had actually given an injection. So I've been working, I'm chair of the Department of Medicine at our local hospital, so I've been working with the IT people, the pharmacy, and other people to see whether or not we can get those vaccines documented where the PCP can actually find them. And then once the patient leaves the hospital, they may go to the nursing home. The nursing home is going to vaccinate all over again if they don't have information sent to them that says the hospital vaccinated the patient. And then by the time they get to our office, they will tell you they got a bunch of shots. They don't know what shots they got, and it may not even be what we're talking about. So that was another level of challenge. Our local pharmacies are also giving vaccines now. Initially, they were not required to put those vaccines in the state registry, but now the pharmacies are required to put the vaccines in the state registry. So I really believe that our patients are being vaccinated a little more than they are. It's just it's not been documented, and if it's not documented, it didn't happen, so we're not really getting credit for it. So the state registry and using the state registry has just been critical in this process. So a little bit about my organization. We are a federally qualified community health center. We actually have 18 service delivery sites in 7 different counties in Southwest Georgia. We're probably the largest community health center in the state of Georgia. In 2016, we provided care to almost 40,000 patients with a total of 150,000 plus visits. Services were provided by 81 providers. We have 33 physicians, 34 mid-levels, 5 dentists, and 9 mental health professionals. So it's a pretty big organization to get organized and cohesive in doing anything. So in terms of our project did not really focus on children. It focused on individuals 65 or older, we really focused on the pneumonia vaccine as opposed to the other vaccines. So I will skip this slide. It just tells you kind of our patient mix. This is our adults 18 and older. Our total patient number is about 33,000 patients. 32% are uninsured, 22% are Medicaid, 11% are dual eligible, 21% Medicare, and 24% are private pay. In terms of our regional statistics, our total service area is about 150,000 patients. Our area is a significantly underserved with health professional shortage area, and we are a medically underserved area or population as well. We have a large low-income population, which are disproportionately Black. Dougherty County alone is about 82% African American. They're significantly uninsured, with low educational attainment and poor health status. Greater than 28% of our service area live at or below the 100% poverty level, compared to 15% of U.S. residents and 18% of other Georgia residents. So our AAPHC income mix of about 47,000 patients, 54% are 100% and below the poverty level. And you can see the breakdown of the other numbers. About 2% are over the 200% poverty level. So I'll skip this slide because this was in one of our older EMR systems, and the numbers are not exactly correct. So we have a system now called Guideline Advantage that allows us to pull data out of our EMR so we know exactly where we are. We found that for providers, as physicians, we have a big ego, so we like to know where we are compared to other people. And if we're not, at the top of the heap, then we're going to work harder to be at the top of the heap, or at least better than the person behind you, because that's who we are. So these are my statistics as pulled out of Guideline Advantage. Our project started in April of 2016, so at the starting point there at 22.5%, that's about where I was in terms of my immunizations for pneumococcal vaccine. And you can see our group as a whole was about the same place, 22.5%. And then sharply in April, when we started giving the handouts, the nurses started using the standing orders. Our physicians were giving speaking points on how to convince their patients to get immunizations. You can see that there's a sharp uptick in April, and we have steadily climbed. And my results as of February were 88.2% of my patients vaccinated. So overall, there was about a 65.7% increase for me from April to February of 2017. My illustrious partner over here, Dr. James Hotz, who is, by the way, the founder of our organization. He started with one clinic in one county, and now, as you see, we have 18 sites in 7 counties.
7 to 97. That's Dr. Hotz right over here.
So as you can see, he went from 7.5% to 97.2%, and again, it was just using these particular modalities. And so you can see, people will say that, African American population, minority population, that's a difficult population. You can't get them to get vaccinated. And as you can see, it just took some very simple tools to increase vaccination rates. Primarily, it was a matter of time and caring and people who really cared. Our nursing staff is just exceptional. They have, huge egos like the rest of us. They're competitive with each other. They worked really hard to get people vaccinated. Initially, they were a little nervous about standing orders and vaccinated people without the doctor giving them the okay. But with our encouragement, with the physicians' encouragement and letting them know it's okay, this is what we want, they took that bull behind, on the horns, and they really got our patients vaccinated. This is another one of our providers who really took this bull by the horn and moved from 31% to 92% from April to February, which was a 61.8% increase. This is another provider, 25 to 95.7% increase. And what is important to know in these slides is that the physician champion or the nurse champion is very important in increasing the immunization rates. So, you know, there are some people whose names have been changed to protect the innocent. So this is one of my partners who never really caught on here. They started out at 14.9%. They only moved up to 37.5%. And what I can say about this particular clinic is that this clinic did not have a champion. And you have to have a champion. You have to have a champion who's there all the time, who's encouraging the nurses, who's really pushing it. When things have fallen off, that champion is encouraging everybody to stay on the bandwagon, and let's get this done. So the champion is just as important as the standing orders for the nurses and as the handout that you give the patient out front. So this is an excellent physician, but it was just simply a matter of there was no champion in that clinic. So their increase, and you see it did increase because the nurses still had the standing orders. So there was an increase from, you know, the initial April amount, but it really requires a champion in your organization. So this slide's a little difficult to see. It just gives you our improvement by, in a different way. I'm there at the top. And I'm at the end of the baby boomer years, so I really cannot see that. But perhaps some of you can see the increases. You see Dr. Hotz, I'm first there, and Dr. Hotz, so you can see how it increased from the beginning, the inception of our program. Down at the bottom, again, you see our non-champion and how they increased. It was a little bit slower. So overall, there was a 72% average increase from April 2016 to February 2017 if you have a champion. Without a champion, the increase was much smaller at 23%. Again, this slide is broken down by our clinics, and these are our adult medicine clinics. We have pediatric, we have dentistry, we have podiatry. So these are just our adult medicine clinics, and you can see how this project really increased our rates. At the bottom slide, the bottom graph there is our ACO participants. The Guideline Advantage could separate that out. Immunization rates are very important because we are a federally qualified community health center. So this helped us to meet some of our goals. It helped us to meet our ACO goals. You know, we have grants that require immunizations. You know, we have other measures that we're held to, like HEDIS measures and whatnot. So when you're able to do something like increasing your immunization rates in your organization, that is extremely helpful to your bottom line as well. We didn't make a mint off immunizations, but we're able to keep our grant funding when we do things like this.
Next session, we'll learn about that mint.
I obviously am electronically illiterate, and I profess to that. Let's see here. Maybe it's the last slide. Is that what it is? Okay, so that was the last slide. So basically, in a nutshell, minority populations, uneducated populations, low-income populations are not impossible people to deal with. They just need a champion. They need people who care. They need a mechanism for reaching them at a level which they can understand. African Americans will accept immunizations. You have to approach it a little different. You don't go in the room and say, well, you know, it looks like you might need a flu shot, but you don't really want one, do you? You walk in the room and you say, you need your flu shot, you need your pneumonia shot, you need your tetanus shot, and I'm going to give them all to you today, and you walk away. And you come back, the nurse comes back and gives them the shot, and they will accept their shots that way. But you know, if you're wishy-washy about it, they're going to say no. They're going to tell you about grandma who got the flu when she got a flu shot, and that pneumonia shot that made them sick and they almost died. But you can overcome all of that, and you can increase the rates of immunizations in your clinic. Thanks.
here. Click that over there. Or you click the top
Well, I was
guy.
clicking that, maybe
You
that
press
was
the
my
white
problem.
Just
There
the
you
white.
go.
arrow,
Just on the
just
right.
on the white.
All right.
My problem.
Great. Whoa. Not used to being microphoned. Hi. Hello, everybody. My name is Patrick Maloney. I'm a PhD candidate at the Louisiana State University Health Sciences Center. And I just want to say how pleased I am to be here among all of you. I mean, a majority of you are clinicians, and you are the folks that are on the front lines out there administering these immunizations and primary care services. So give yourself a pat on the back, and I think a round of applause for you guys, too, because you guys just do an awesome job. Okay. But I'm here today to present on a project entitled Identifying Barriers and Facilitators to Providing Adult Immunizations Among Majority-Minority Serving Physicians. Now, this is a project that is going to be completed in coordination with the American College of Physicians, National Minority Quality Forum, the Louisiana State University School of Public Health, and Healthcare Services Division. So, today, I'm going to talk a little bit about the disease burden of influenza and pneumococcal diseases, a description of adult immunization rates for those diseases, and I'm going to present a conceptual model that we've developed as well as a 3-phase plan to hopefully increase immunization rates and identify those barriers and facilitators to immunization. So we know that influenza afflicts approximately 5 to 20% of the United States population in any given year. This includes 200,000 hospitalizations and between 3 and 49,000 deaths. Now, this is despite the fact that we have a highly effective vaccine. For the 2015-2016 influenza cycle alone, CDC estimated that the annual flu vaccine prevented 5.1 million influenza-related illnesses, 2.5 million medical visits, and 71,000 hospitalizations. Now, it's troubling that despite the severe morbidity and mortality inflicted by the flu and our highly effective vaccine, that immunization rates remain low among adults in our general public. Now, just to give you some perspective, Healthy People 2020 goals for those aged 18 and older for the proportions of influenza vaccine that they should be receiving is 70%. Overall, we're fluctuating between 38.8% and 43.6% over the last 5 influenza seasons. So as much as 30% reduction in that rate where we're supposed to be. Now, that rate in 2015 and 2016 was 41.7. Now, these numbers are even more troubling when we look at them stratified by race. Now, white folks do slightly better in the overall numbers of immunization rates as compared to that overall number, but those numbers still fluctuate between just 41.9 and 46.7%. Now, it's troubling when we look at the numbers for African American individuals. They receive the influenza vaccine yearly in much lower proportions than that overall number, with rates fluctuating between 32.7 and 38.7% over the last 5 seasons, or 6 seasons, with their rate being 36.6% in the 2015-2016 season.
It's terrible.
These results are even lower for Hispanics, who have rates that fluctuate between 29.4% and 35% over the last 6 seasons, with an immunization rate of 34.4% for that 2015-2016 cycle. So we're going to shift gears and we're going to talk about pneumococcal diseases for a minute. Now, pneumococcal pneumonia causes or accounts for approximately 36% of all community-acquired pneumonia, leading to 400,000 hospitalizations annually, and has a case fatality rate of 5 to 7%. For every 100 individuals who become infected with pneumococcal pneumonia, 5 to 7 of those individuals are dying. Now, pneumococcal bacteremia and pneumococcal meningitis have significantly lower counts of cases, but much higher case fatality ratios. For pneumococcal bacteremia, the case fatality ratio overall is about 20%, but when we get to elderly individuals, we're talking about case fatality ratios as high as 60%. That's 60 out of every 100 individuals over 60 with pneumococcal bacteremia dying. Now, pneumococcal meningitis, the case fatality ratio is 8% for children, but can be as high as 22% for adults. Now we have a highly effective vaccine for these pneumococcal diseases, and we have severe morbidity and mortality related to these diseases, but similarly to influenza, we are not doing a very good job at immunizing. Healthy People 2020 goals say that for those over 65 years of age, we want to be hitting 90% immunization rates. Yet our overall rate for the last 6 years has fluctuated between just 59.7 and 62.3%, with 61.3% being the rate in 2014, which is the last year the data are available. Again, we're going to see similar trends here, troubling when we stratify by race. Whites do a little bit better than those overall numbers, with rates fluctuating between 63.5 and 66.5%, but African Americans are experiencing significantly lower rates of immunization, fluctuating between rates of just 44.8% and 49.8%. Now that 49.8% was the highest number in 2014, which was the last year we had the data for. And again, the rates are most troubling for Hispanics. Now the rates for Hispanics have fluctuated between just 39% and 42.5%. So all of this begs the question, what are the reasons why individuals are getting immunized in such low proportions? And perhaps more importantly, why are individuals who are African American, Hispanic, and of other minority groups receiving immunizations in such greater, lower proportions than those individuals who are white? So we've developed a conceptual model to help explain this phenomenon. Now, we take into account that there are obviously individual factors that are contributing to these low immunization rates, such as race and ethnicity, formal education, native language, immunization literacy, socioeconomic status, and insurance status. However, there are greater level constructs that we often don't address in the literature that we need to take into account if we want to holistically assess this situation. And those include structural barriers and attitudes and beliefs. Structural barriers can be further divided into access to care and provider practices, and attitudes and beliefs into resistant and non-resistant beliefs. And we're going to discuss those more in future slides. But basically, all of these factors together influence an individual's immunization behavior, which influence our immunization rates, which ultimately influence our disease-related morbidity and mortality. So we're going to begin by discussing resistant beliefs. Now, a resistant belief is a belief that would prevent someone from accepting the immunization, even if that immunization were free. So examples of this could be the belief that the immunization would cause the illness, fear of immunization-related side effects, a belief the immunization doesn't work, or even the doctor recommended against the immunization. Now, there's some research to indicate that the highest prevalence of these beliefs are in African American individuals. And as you may be able to see or logically intuit, interventions for these type of beliefs are extremely difficult because you have to go in and you have to dedicate significant time to overturn these ingrained beliefs in individuals. So this would involve a significant education of your patient population. So non-resistant beliefs are beliefs that would not prevent someone from accepting the immunization if it were free. So these would be things such as not knowing that the immunization is important, the doctor did not recommend the immunization, or the belief that the cost was simply not worth the money. Now, these lead to much easier intervention strategies. Now, we could introduce efforts to increase provider recommendation. These could be standing orders, for example, as Dr. Ferguson was talking about. It could also include in-office marketing, such as posters and brochures. Now, moving on to structural barriers, the first structural barrier that we're going to talk about is access to care. And this can really be broken down into access to care is the ability of individuals to obtain immunization. And this can be broken down further into two categories: the ability to afford the immunization and the ability to access the immunization. Now, insurance status is obviously going to play a very important part in that first aspect, the ability to afford the immunization. Now, we know the ACA has been immensely successful in expanding insurance to those who were previously uninsured, to the tune of 20 million people or so. However, we also know that minorities remain disproportionately uninsured compared to non-minorities. So if you are uninsured or simply underinsured, immunizations can become very, very costly for you. Now, you can also have issues with the ability to access the immunization. So that would be the immunization not being available at locations that are convenient to you, or you're unable to reach clinics, pharmacies, or primary care locations where the immunizations are being offered. Now we're moving on to sort of the meat of this conceptual model that is going to inform our future three-phase plan. Now, the final structural barrier is a barrier dealing with provider practices. And the fact of the matter is, the literature describing the provider's role in immunization behavior is sparse. We do know that one of the single best predictors of increasing immunization is to have the provider recommend it. But beyond that, we have very little information about those organizational barriers, about provider barriers, and about individual patient barriers dealing with the providers that can inform immunization rates. So our LSU working group, in conjunction with ACP and the National Minority Quality Forum, hypothesizes that there are several potential provider-related factors that could influence these immunization rates, such as the availability of vaccinations. Do we have the ability to offer pneumococcal vaccines in our practice, or do we not have vaccine fridges, for example? Are we providing vaccines in-house? And if we're not providing them in-house, are we writing prescriptions for individuals to go to retail pharmacies to get those immunizations? There could also be issues with the ratio of physicians and support staff to patients. Do we have enough physicians? Are we spending enough time with our patients? Are we able to spend enough time with our patients to really educate them sufficiently to increase their immunization rates? There could be other general conditions of the practice. Do we have enough space, for example? Current vaccination policy and current vaccine interventions. Do we have standing orders for every person that comes into the clinic, for example? So all of this has fed into this three-phase plan that LSU, ACP, and NMQF have developed. Now, our goal is to identify, assess, and practically test potential patient, provider, and organization-level barriers and facilitators to providing adult immunizations among majority-minority serving physicians. Now, we've heard me say that word a few times, majority-minority serving physicians. So what does it mean, and why are we interested in them? A majority-minority serving physician is a physician who sees greater than 50% of their patients having minority status. So greater than 50% of their patients are minorities. And we're interested in them because minorities are being immunized in such drastically lower rates than other racial and ethnic groups, or non-minorities. So this leads us to our three-phase plan. We plan to conduct focus groups, a provider survey, and intervention studies. Now, our focus groups, our goal is to go in and qualitatively assess and identify potential patient, provider, and organizational level barriers and facilitators to providing adult immunizations. And we're going to do so by establishing two groups: those physicians that are immunizing in low proportions and those physicians who are immunizing in high proportions. And we're going to provide questions to those individuals about those factors that could influence immunization, like organizational policies, personal perceptions and practices, and reasons that individuals are denying the immunization. Now, this isn't meant to be critical of those individuals who are in that low immunizing group. Not at all. We're trying to identify what potential barriers that those individuals experience. Are they patient-level barriers? Are they organizational-level barriers? Ultimately, we want to find out what those barriers are so we can address them.
Surely the recruitment letter will not say, "Dear low-performing physician," right?
No, of course not. It's a little more tactful than that. But The responses of this qualitative study are going to inform a quantitative study. So we're going to pool those responses, develop a survey tool that allows us to quantitatively assess the potential patient, provider, and organization level barriers and facilitators to providing immunizations. Now, this survey is going to assess those behaviors, beliefs, practices, and policies that the focus groups have identified as influencing immunization. We're going to distribute this survey among majority-minority serving physicians who are ACP members, and then we're going to statistically, epidemiologically assess the importance of specific behaviors, practices, beliefs, and policies. Now, it's great to say we're going to go in and we're going to statistically assess those measures, right? But let's talk about how that's going to translate to clinicians. Because one thing that falls out as being statistically significant for us isn't going to translate to your practice necessarily. So we need to identify behaviors, practices, and policies that can increase immunization, but can also translate to you, the clinicians. So we want to design, develop, and test interventions to promote those behaviors, policies, and practices, but we also want to test the effectiveness of those methods and if they can actually work on a higher scale as opposed to just with that individual physician. So, thank you conclusions. Just to reiterate, overall national immunization rates fall drastically short of Healthy People 2020 goals, despite the ability of those immunizations to reduce morbidity and mortality, and despite the fact that those immunizations are highly effective at preventing disease. Now, this is especially true in minority populations. However, that role of the provider in influencing immunization behavior remains poorly understood. But with this three-phase plan, we can better understand the role of the provider in immunization behavior, and this understanding will hopefully allow us to modify behaviors of providers and maximize immunization rates. And that's it. Thank you so much.
So we do have a few minutes for questions if any of you are interested in asking our distinguished guests. Sir?
Good morning. Andrew Sanderson from the Office of Minority Health. Thank you all for your presentations. Dr. Ferguson, my question is for you. I like the run chart that you showed with the increase in the providers' ability to provide immunizations. You talked about the importance of champions. Is there any way that you all incentivize or rewarded champions in those groups? And then the second part of my question is, your benchmark was at 30%. Have you thought about increasing that benchmark at some point?
The benchmark was just something that was automatically put in there by the program. The Guideline Advantage program chose that 30% benchmark. That was not really our benchmark. It was just automated into the system. And then secondly, in terms of our champions, we did not incentivize them, but it's something we thought more about incentivizing our nurses because they are the ones that really got the immunizations out there. And so for them, we thought of either like monetary or gift card kind of incentive for the nurses who got more patients immunized. In terms of our physicians, we felt like the incentive was that, we meet our goals. We meet our HEDIS goals. Our organization has to keep going. We have to keep our grant money. So we didn't really incentivize our providers. They just jumped on that that bandwagon because our CEO and our quality officers are always talking to us about our productivity and our performance and meeting our measures. So I think the providers kind of got on that without necessarily being incentivized.
So did you have a particular percentage as a benchmark for providers?
Initially, when we started our project, we just wanted to increase by 50% from where we were, and we actually well exceeded that goal. We just kind of chose a percentage, the original champions by which we wanted to increase, and as you can see, most of us increased far above that 50% mark.
Great, thank you.
Hi, this is Dr. Westcott from North Dakota State University. I have to say, as a med student, I saw a case of epiglottitis, which you never see that except on the boards, and still that family, in spite of their child almost dying, I was in a rural hospital, no pediatric ventilator, we had to medevac the child. It was very dramatic. Fortunately, he lived, but the parents still refused to immunize that child and their infant. So, that resistance to immunization, even though I had seen a near fatal case, was what made me become a super vaccinator. And I'm wondering, I love what you're trying to do now with those who are in practice, but I feel like if you don't start in med school, and obviously we can't give med students cases to see necessarily, but if we focus on the curriculum, that might be a more effective way to get people interested and become super vaccinators.
We actually have extended this program to residency training, not med school, and they've been very productive in that environment. I don't know if Suja Matthew is here. We worked with Cook County Health System and realized great improvement and started inspiring at least younger doctors along the way.
Yes, and there was a program. Didn't you all have the program with the residents where they challenged each other to increase the immunization rates in their clinics, and they did just tremendously well with that. And I think that patients listen to their doctors. As you know, there's a very close relationship between patients and their physician. And if the physician really champions something and tells their patients that they really need this, they tend to listen to it. Because I find even after my patients, they get past the front desk and they get past the nurse and they still don't want it, I can just go in there and say, you really need this. And that is kind of the end of it. And they will go ahead and do it.
Thank you.
So good morning. Are we still in morning? Yes. My name is Shanta Whitaker. I'm with Logistics Management Institute. And a quick question just about the data. I am trying to understand the adult population you guys are assessing. Are you looking at from the full spectrum of adults? Are you looking at elderly adults? And also for protective measures, are you seeing potentially a decrease in the health disparities among minority groups when you get to the Medicare Advantage population?
Who was that question for?
Anyone, because you all show data.
Well, I can speak for my group, Guideline Advantage. We looked primarily at the adults over 65 because that's what our project was focused on. But, my nurses, their standing orders also gave them guidelines for high-risk patients, our diabetes patients, asthma patients. And so our rates really went up overall for all of those patients, but the data was specifically for individuals that were 65 and older. I think perhaps it's too soon for us to determine, what effect that will have overall on health disparities. But according to your data and other data, increasing immunization rates in the long run, obviously, will decrease morbidity and mortality from diseases that could be prevented by immunizations.
Yeah.
I just want to warn everyone, we have about 2 minutes left. So we'll try to get everyone who's standing up a brief time, and that'll be it. So, sorry. I think you were next.
Okay, thank you. Great talk. Talithia McBride with GlaxoSmithKline. Hi, Bernie. We have a long history in the quality measurement space. So I had a couple of questions. One, with respect to all of your projects, are there any thoughts regarding how this can influence what federal activities should take place? So given the fact that there are no mandates around physicians or pharmacies reporting into state-based IAS systems, it's not mandated the same way that childhood immunizations are expected to be reported. Any thoughts to how what you're doing within your states, within Louisiana, within Georgia, your projects, how they can spread, and is there an opportunity to influence federal legislation or at the federal level? And then second, with respect to your project in Georgia, what are your goals with respect to trying to spread that across the ACIP CDC schedule? So, trying to raise, adult immunization rates
I can
across the
kind
entire.
of briefly address that. I think as a group, we're meeting later this week, actually, and that will be on the agenda, kind of talking about translating our results into, a broader dissemination and policy. I know I'm speaking at the CDC Summit in May, and we'll be sharing these results. So I would just like to thank you for the question, so it impresses upon all of us the importance of not just succeeding, but then helping others succeed. Dr. Davidson.
Well, congratulations. I think it's an unmet need. I give a lecture of immunizations in patients with diabetes.
Right.
And the first thing I do is I ask the physicians and the nurses, how many of you had the flu shot this year? And I think the answer is very simple. Charity starts at home. Because if we don't take those immunizations, then we're not going to prescribe them to patients. So, you're doing a lot of good work. I think it's time for us to actually partner with ADA and ACE and other organizations, especially minority organizations, which we have a lot less immunizations than the regular. But I tell you, it's dismal in the endocrinology world. They are really not aware, even though we have a CDC website in Spanish says, vacúnese hoy, we're not doing it. So I want to congratulate you. There's a lot of work to be done. I recommend that we start working with organizations such as ACE, ADA, anybody that can help us. You don't see any programs for immunizations in any of the annual congresses. So congratulations.
That's a wonderful question and point, because I think we have long wanted to bring these kind of interventions into some of the chronic conditions that put patients at greater risk of, dying from the illness. And you are chairing our new effort, Diabetes 2020 Vision, and so I think this should be one of our interventions in the community and the practices, sir. Thank you for that question.
No, thank you all for the effort.
Do we have one last question?
I'm
Oh, you've got usurped.
Oh, I'm sorry.
Hi, my name is Sharon McGraw. I'm a registered nurse, and Dr. Ferguson and the panel. What I want to say is that I have worked for 3 different companies that do immunization. One company that I worked for, they had the computer system set up where they would have to stand in order right there in the computer system, the manufacturer of the vaccine, whatever site you gave, right or left site. If you have any comments or any concerns, you can also document that right in the electronic chart, and the patient can get a copy of it. Even for a TB, when you first get the TB shot, you would just document where you gave it, and then they would come back for their 48 to 72 hours later, and they could also get a copy of that. Then I worked for a couple other companies where we went into the school system, and we worked with this nurse, where the nurse would get the permission from the parents, and then once we vaccinated the kids, we would give them a slip telling them, take home to their parents, let them know what they got. And then another company I worked for, we went to big corporations, and the nurses would give immunization shots, and sometimes it would set up to be a trio where they did the immunization shot, they did the blood pressure and the cholesterol check all at one. So in Baltimore, Maryland, we was doing that. So